Hey everybody, this is Adam again, and the next couple of videos you're going to watch are going to be on procedural sedation. So this module speaks about just general concepts in sedation, and I think by the end of this one, you should be able to tell me about the staff and the skills and the monitoring equipment that you might need for a sedation, and you should also be able to recognize when a patient is just not someone who's appropriate for sedation in the ER. So we think of sedation as existing along this spectrum that ranges from minimal sedation all the way down to general anesthesia. Minimal sedation, I think, is pretty easy to recognize. So this is somebody that you've just given an Ativan to. They have a normal level of responding and their ABCs are unaffected. Moderate sedation is a little bit deeper. So this is somebody who's pretty woozy, pretty sleepy, but if you talk to them, they'll talk back to you. And usually their airway and their breathing and their circulation, you don't have to do anything about it if they are affected. They usually support themselves pretty well. Someone who has deep sedation is somebody that's pretty out, and to get them to respond, you've got to pinch them, or you got to do a sternal rub, or you got to do something painful to get them to move. When someone's this deep, their airway might need some help, and their breathing is probably okay on its own, but it needs close monitoring because it might be inadequate. Their circulation, though, is usually not that significantly affected. And general anesthesia is basically what they do in the operating room if they're going to pull out somebody's gallbladder or appendix, right? This is somebody who does not respond to pain, and usually their airway and their breathing are affected enough that there's got to be some kind of intervention to support it because they're probably not protecting that on their own. And their circulation gets to that point where it might be starting to get impaired there. When we talk about procedural sedation, we're usually referring to deep sedation. And what level of sedation you need sort of along this spectrum very much depends on the procedure. So if you're doing a fracture reduction, you're going to need somebody deeper than if you were doing like a laceration repair or something like that. Minimal sedation you're very familiar with because that essentially just refers to anesthesiolosis. And we do this sort of thing all the time. So every time you give somebody lorazepam or Haldol or something like that, you're doing a little bit of sedation. And I think that concept is important to keep in mind because I think we all have a story about some elderly person that we gave like a little bit too much lorazepam to, and then we just sort of slid into moderate sedation. And at the time, you may not have thought about that as sedation, but remember, if somebody's airway and breathing are starting to get affected, there's some debate about whether or not you should be moving this person to a monitored setting. I think a lot of it depends on what drug you gave and how long you expect it to act, but that should be something that enters your brain at that point. Sedation always carries some risk to someone's blood pressure, to their respiration, and to their airway. And I think this is a lot more common than people who are new to this realize. So just to give you an idea, oxygen desaturation can occur in up to 10% of people that are using propofol. So when you're sedating someone, you have to have airway skills to do this, especially if you want them to go deep. Now, luckily, most of the effects that they get are pretty transient, and there's some argument about whether some of these effects are clinically significant. So, if your O2 sat drops down to like 88% and it stays there for 10 seconds, yeah, that's hypoxia, but is that really going to hurt anybody? Sort of up for debate. But you should always be asking yourself, if somebody were to get hypotensive or hypoxic or something like that, would I be able to manage it? And specifically, you should be asking yourself, would I be able to manage it in this patient? Because someone who's like 25 and super healthy is going to be a different game if they're, like 70 and obese. You You should also ask yourself about the patient factors too. So that 70-year-old obese person, are they going to be able to tolerate a brief bit of hypoxia? Is this somebody that's got heart or lung problems where that might be a more significant issue? You've got to do that risk assessment before you go in. So your risk assessment starts with just a focused history and physical of the patient that you're going to sedate. So you'll want to talk to them and ask them about any prior surgeries or any problems that they may have had with old anesthetics, just so you know what to expect and to see if there's anything there that you could sort of head off before you get into it. We also usually ask people about their fasting status, but to be honest, it probably matters a lot less for the stuff we do in the emergency department, partly because our procedures are just so brief, so the risk of them aspirating or choking or something like that is pretty low. Now, if it's not like a true emergency and you don't have to do anything right now, and the patient you're talking to is like eating a cheeseburger right in front of you, it's probably in your best interest to just delay things a little bit. But you'll see lots of variation in practice there because the evidence doesn't really support that. When you examine the patient, you're looking mostly at airway, breathing, and circulatory systems. And the idea here, I think, is if you find something, you should make some attempt to fix it. So if you have a patient that looks a little bit dry, you should probably give them a bit of fluids to support their blood pressure when you start sedating them. Or if you hear some wheezes and this person has a bit of mild asthma, it's probably worth giving them some puffers just to make sure that their oxygen status is as best as it could be. If you find things that you can't fix, the question will be, what's your plan to help mitigate that risk? And the things that will give you pause will usually be the risk factors that you notice around bagging or around intubation that might make things difficult. As far as bagging goes, there's a mnemonic you might remember called BOOTS. So the B stands for bearded patients, because if you have a beard, sometimes the mask just doesn't seal against the hair. And you can get around that by sometimes putting a little bit of gel on the mask to just give it a better seal. And sometimes you can use an oral airway or the two-person technique to get around it. The O stands for older patients, because older patients will sometimes have issues with neck mobility or jaw mobility and that sort of thing. And you can sometimes mitigate a bit of that risk by just positioning people upright, or sometimes using an oral airway again can help. The second O is for obesity, and we know that obese patients just have excess tissues around their airway, and sometimes when they're lying flat, that collapses back and creates obstruction. So if you position them upright, that sometimes mitigates that risk. The T stands for toothless, so people that don't have teeth are missing a bony structure that helps support some of the skin around their face. So if the skin sags in, then sometimes the mask doesn't seal very well. So if people have dentures, you should actually leave them in when you're bagging them, because it makes things a lot easier. And sometimes an oral airway helps to just sort of move some of those tissues around a bit. And the last thing is sounds. So that refers to stridor or wheezes or snoring or any kind of sounds that might indicate there's an airway obstruction, which you try to mitigate with either the two-person technique or using an oral airway. Now, somebody once told me that this is basically just like Santa with no teeth. So I kind of keep that visual image in mind, and I find that easier to remember and run through than the boots thing. And to be honest, I don't think too hard about the plan, because for me, I position every patient that I'm about to sedate in an upright position unless there's some reason that I can't do it, because that already solves a bunch of problems. And if I have any sort of difficulty with bagging, my first go-tos in every case, regardless of the cause, are going to be putting in an oral airway and then using that two-person technique. So if you keep both of those points sort of in mind for every sedation, then the only thing you really got to remember is that if the patient has a beard, you should gel the mask, and if they have dentures, the dentures should stay in place. There's another mnemonic for difficult intubation. The one I learned was MAP. So the M stands for Mallampati class, which you'll remember is this thing. So when you look inside somebody's mouth, how much of the soft tissues in the uvula can you see? And if you end up as a class 1 or a class 2, that's probably going to be an easy intubation, and class 3 and class 4 is usually a harder intubation. The other M stands for measurements. So the 3-3-1 rule is something you want to know. So the first two threes refer to mouth opening and the thyromental distance, and they should be 3 finger breadths each. And the 1 refers to this jaw protrusion test. So people should be able to slide their jaw forward about 1 finger breadth. And the easiest way to sort of determine this is just to get them to try and bite their upper lip. If they can cover the vermilion border, then they've got 1 finger breadth, and it should be okay. The A stands for atlanto-occipital motion, which is basically just neck flexion and neck extension, and how easy is it going to be to get them into that sniffing position. And the P stands for pathology. So if you look inside their mouth or around their face and neck, do you see edema? Do you see infection? Do you see markers for a tumor? Is there vomiting? Is there blood? Is there soot? All that sort of stuff should give you pause for sure. Now, interestingly, in procedural sedation, markers for a difficult intubation is really only a relative contraindication to the procedure, because the chance that you'll actually need to intubate somebody in a sedation is well under 1%. Really, the risk of difficult bagging is actually much more important, because if somebody does become hypoxic and you oversedate them a little bit, bagging them is going to be the main mechanism for supporting their respiration until things wear off. And as well with bagging, you can plan for and you can mitigate a lot of the problems that come along with that. So you can talk to the nurses about the two-person technique, or you can make sure that you've sized an oral airway or sized masks. And you can almost sort of get like a practice round too, right? Like you could take a mask and put it on their face and see if it fits. You could try putting gel on and see if that actually works even before you go into the sedation. When you prep to sedate somebody, I think you've got to do basically the same prep that you would do if you were going to intubate somebody. So I have a mnemonic for this that I use called STOPIC. It's a dumb mnemonic, but it's just always worked for me. And I think you need to have some sort of mental checklist for this sort of thing to make sure that you don't miss anything. But in my mnemonic, the S stands for suction, the T stands for tube, the O stands for oxygen, the P stands for positioning, the I stands for IV access, and the C stands for CO2 monitor. And I think setup does vary a little bit between sedations and intubation and that sort of thing, and certainly between staff members as well. But as an example, like if I was tubing somebody, I would get an endotracheal tube, I would properly size it, I would put a stylet in it, and I would test the cov. But if I was just sedating somebody, I probably wouldn't do anything except know that I've got the tube and that I've got the right size of the tube. So you don't have to do everything that you would do, but you got to get at least sort of the equipment and at least know that it's all there. The CO2 monitor thing, I think, probably deserves a little bit of explanation because you probably aren't super familiar with these. But this spits out a graph on the monitor where the x-axis is time and the y-axis is just how much CO2 is coming out. So you can go really deep into the weeds with these things, but basically what you need to know is that when the line goes up, that's a person breathing out. And when the line goes down, that's a person breathing in. And you just got to watch it because if the line looks like that, that's apnea and that's somebody that you've got to intervene on. Ideally, when you do a sedation, you've got two physicians. So you've got one person that can do the procedure and one person that can just do the sedation and focus on ABCs. But if you're a single coverage place like we are, usually you're going to end up getting a nurse to monitor the respirations, and that's totally fine too. And that's the end of the first module. So just to summarize, procedural sedation is a spectrum, and it ranges from just gentle anxiolysis to general anesthesia. And the depth of sedation that you need really depends on the procedure that you're going to do and the patient's risk factors and your ability to manage the risks that might come through. Remember that sedation always carries some risk of hypotension, of respiratory depression, and of airway compromise. And you need to be able to recognize the risk factors, especially for difficult BVM. If you can't adequately mitigate some of those risks, this is a person that you probably shouldn't be sedating. You should be looking at doing some other alternative procedure, or you should be consulting somebody to help you with this. And that's it. So we'll talk more about some drugs in the next video, so I hope you'll tune in for that.